Hi there, Kendra Tolbert here. I'm a registered dietitian and yoga teacher, and I specialize in women's health and fertility. Today, I have an interview for you. It's an interview that I did with Dr. Shvetha Zarek, who is a reproductive endocrinologist here in St. Louis, where I currently live. She was gracious enough to answer your fertility and reproductive health related questions, and I am beyond grateful to her and so excited for you because she truly is an expert in the field of fertility and reproductive health. She is an award-winning reproductive endocrinologist and amongst the best of the best. So let's dive right into this interview with Dr. Shvetha Zarek. Hi there, Dr. Zarek. Thank you so much for taking the time to chat with me today.
Yeah, absolutely. Thank you so much for having me, Kendra. I really appreciate the opportunity. I'm very excited to be talking about our two kind of passions and topics because they go hand in hand, as you know very well.
Absolutely. So before we dive into the questions that people submitted, I'd like to know more just about who you are, why you do what you do, and what do you do?
Yeah, so my name is Shvetha Zarek. I guess I'm supposed to add the doctor. So Dr. Shvetha Zarek. I am a board certified reproductive endocrinologist and infertility specialist. I will say I don't love to say the word infertility. We like to have a positive framework for it. So we usually say fertility specialist overall. And I've been practicing in Missouri and Midwest for about 10 years now. And before that, I was on the East Coast, actually, where I am originally from and did my training in Washington, D.C. And we were chatting before about how you have a pretty strong connection to Washington, D.C., which I love. But we absolutely love the Midwest, and the we is family and dogs and kids, all of that. So we've settled in quite nicely here. Our passion with at Arbor Fertility, which is the name of our practice, is to provide more affordable fertility care with price transparency without cutting anything in terms of the quality of care in general, either success or just how much the patients can communicate with us. So I'm really proud that we're able to have a concierge practice. I think it's very much so needed in the fertility world overall.
Wholeheartedly agree. I was taking a look at your website. I mean, I've been to it quite a few times, but I am definitely impressed by the price transparency because you really do list everything out and what people can expect because the price tag can be a bit of a shock during an already difficult time. So thank you.
It really can. Yes, yes, I appreciate that. And we are always looking to improve. So I'll tell you what I tell all our patients in our community is that please continue to give us feedback, all of it constructive. We can only improve. And that's part of why I was so excited for us to connect today, because I feel like there is an opportunity in our practice to do better with fertility and nutrition, a huge opportunity, and so this is something where I'm hoping we can put our heads together and multiple more and kind of come up with something that feels a little bit more supportive for the patients, other than, 30 seconds of this is what you're supposed to do. Let's move on.
Very good. I think that says a lot about the quality of care that you want to provide to people and the quality of care that you are providing to people, which kind of leads me into my first question for you, which is why did you become a no, actually my first question. The other question is what is a reproductive endocrinologist? Can we define that?
Absolutely. That's a great question. So it is a fellowship or a subspecialty of OBGYN. So, kind of first physician, and then the specialty part is I'm an obstetrician gynecologist, board certified in that. That's 4 years of training. And then another 3 years of fellowship for reproductive endocrinology, which we shorten to REI. So if you hear anyone say I'm an REI physician, it's not the amazing outdoor company we're talking about. It's in our world, it's for fertility.
Awesome.
So it's such a long word. I usually just say I'm a fertility specialist.
Very smart move. And it tells us in part what you do. Can you actually talk a bit about what else maybe reproductive endocrinologists do? Do reproductive endocrinologists only help people who are trying to conceive, or do you also help manage other conditions?
So we do help manage other conditions. I will say a lot of fertility practices have chosen to focus only on the fertility, which for the most part we do. That said, you can be seen for, I'm just going to put some diagnoses out there, some of which I think your community had asked questions about. Endometriosis, which is a common gynecologic disease that can cause significant kind of pain and decreased quality of life. That's one thing that's kind of in that reproductive endocrinology world overall. There's something you may not have heard this, and if you have, that'd be amazing. Mullerian anomalies, which is actually where the shape of the uterus is actually abnormal. And there's actually many different variations of what that could look like. I don't actually love the word anomalies because it's actually much more common than you would think. But that said, that's something that we may discover and someone may not necessarily be ready to conceive.
So when should someone reach out to a reproductive endocrinologist like yourself?
So it is age-based. And so we use age 35 as a cutoff. So if you're having regular menstrual cycles, it's trying for about 12 months before the age of 35. And after the age of 35, it's after about 6 months. That said, most couples who are going to conceive within that first year will do so within the first 6 months. So anything after that is considered subfertility. If it's kind of month 7 to month 12 overall, there's probably some kind of subfertility component to that. So that is kind of general rule of thumb.
Yeah. Do people have to wait until after they've been trying to conceive for that long? Can someone come in if they're just curious about their fertility?
Absolutely. We encourage that, certainly just so they can understand what we're doing in terms of the testing, what we can kind of accurately tell them and interpret their results. So common testing is kind of blood work to look at hormones that affect fertility. There is a blood test that we can do called AMH, which stands for anti-Mullerian hormone. And that gives a sense of ovarian reserve. It kind of helps put someone's egg quantity in a category of low, normal, or high. That's useful. It's useful in terms of kind of planning for the future with family building.
Awesome. We actually had a question about AMH, so I'll go ahead and ask you that
Yeah, absolutely.
question. So this person asked, after losing 10 kilograms, which I think is about 22 pounds, my AMH is more than 23 nanograms per milliliter. I have done laparoscopy for ovarian drilling. Now, what can I do to lower my AMH level? Is it possible to conceive without IVF? So let's dive into, there's multiple parts there.
Yeah. I loved that question, and thank you for sending that because I had never had anyone ask how to lower their AMH, and I'll talk a little bit about why. So it sounds like this person had a history of polycystic ovary syndrome or PCOS. That is a hormonal imbalance, usually an increase in testosterone, but it's actually kind of insulin mediated. So kind of a lot of general health related there. And it can kind of stop your menstrual cycles. So we call it secondary amenorrhea. You had cycles to begin with, and then it stopped, probably related to the hormone imbalance. The first part in terms of the laparoscopic drilling is a very old school, but like super effective method to kind of help overall with restarting ovulation. So the thought is with PCO ovaries, this used to be called Stein-Leventhal syndrome, that they not only there's an increase in cyst, hence polycystic, but the actual tissue, the stroma, right, where a follicle has to release from, becomes thicker and tougher. And so the actual follicle has difficulty releasing, hence it doesn't release. And then you get that kind of classic string of pearls around the ovary of the follicles. That's the thought. So the laparoscopic drilling helps with kind of release that tissue so it's easier for the follicles to then ovulate potentially overall. So I love that that person discovered that because it worked very well to kind of resume ovulation. We have now kind of utilized medications more, but I think there's a great utility to these surgical interventions. And for the other part of their question, kind of lowering the AMH, by golly, there are so many folks who have really low ovarian reserve and AMH. And there's really not much we can do to kind of change that. So I would say instead of looking at the AMH as kind of a goal to lower it, it would be more a resumption of ovulation. If there was any kind of markers that are kind of related, higher blood pressure, lower hemoglobin, or higher hemoglobin A1C, kind of normalizing those markers more than the AMH going down. I would say celebrate a high AMH overall. I mean, we're used to working with folks who sometimes have like virtually close to zero. So
Yeah.
we'll take a higher one anytime.
Yeah, I definitely get a lot of questions from people asking how they can raise their AMH. And it's
Yeah.
something that I sometimes just wonder if people are, because I know there are these at-home tests where people are taking them at home and it's a standalone test. And it seems that a lot of people are under the impression that the standalone test tells them whether or not they can conceive on their own.
Yes.
Can you please speak to the limitations of AMH and what it can tell us and can't tell us?
Absolutely. That's a great question. And so it also reminded me to put the PSA out there that AMH is a marker of egg quantity. It tells us nothing about egg quality, and ultimately quality matters the most. So, this is a common question we get. I'm curious about my fertility. I'd like to know if I'm fertile. Can we do testing? And can you give me the answer to that? And while we can provide a lot of answers, unfortunately, we can't provide the answer of, will I be able to conceive or am I fertile? And, kind of intuitively, it starts to make sense why. In one version or another, it takes two to tango, right? So we have to like look at the sperm component if that's kind of part of the equation. And also kind of things can fluctuate quite a bit. So really the only way to know if you're fertile is to attempt conception.
Hmm. Yeah.
So we can help, let's say if someone's not having menstrual cycles, which means they're not ovulating, we can support that, right? And that's kind of a place to start.
Yeah. No, that makes tons of sense. So, this last part of this person's question, is it possible to conceive without IVF? I'm assuming they're saying based on the little bit that you know about their health
Yeah,
history, right? And it's not their
yeah.
full health history. We can't fully answer that because I'm assuming you'd have to know a lot more about them.
Correct. But in general, let's assume that everything else was normal and everything else would be open fallopian tubes, all the other hormones are balanced and, normal semen analysis. Let's just kind of put that out there. Then yes, absolutely. They can conceive. Don't necessarily need in vitro. We like to approach it with kind of a lower intervention first and then kind of move to higher intervention. There aren't a lot of really great choices for fertility treatment because there's kind of lower intervention with ovulation induction. And there isn't really anything that's become adopted into standard practice that's middle, and then there's in vitro,
Yeah.
So, that part of the bell curve is kind of missing overall. It would be nice to kind of have something there in between.
Thank you for that.
Yeah.
This kind of leads us into another question. Someone was wondering, let me see, let me find the exact question. Thank you for this. I am 32 and I was diagnosed by laparoscopy with stage 1 endometriosis and possible adenomyosis. I've been trying to conceive naturally and via IUI for a little over a year with no success. When should I consider IVF? And so I also want to break this one up a little bit. At what point would you typically move on from IUI to IVF? And are there contraindications for either of those when it comes to treatment?
Oh, yeah, that's a great question for the person who's kind of living this journey right now. And I will just say that it's incredibly common to hear this story, certainly with stage 1 endometriosis. So the kind of short answer is that generally the data shows that 3 ovulation induction and IUI cycles, which are combined, right? So that's about 3 months of treatment is usually what's recommended before at least considering IVF. So the success rates are all kind of age dependent for IUI or intrauterine insemination, but at its highest, it's probably about 15 to 20% at the kind of the best egg quality kind of data. So once we get to about 3, what I call solid IUIs, meaning that we know we've kind of captured ovulation and had a good insemination with good numbers of the sperm and also the technique. If we're not seeing success, generally, that's when I usually say it's time to at least consider IVF. And some people are open to that and some people are not. There is very good data to show like a 5th or 6th, all the way up to 10, 12 IUIs. With every additional cycle after 3, if you take 100 couples, maybe 1 or 2 will be successful. So it's a like more and more diminishing return, odds of return overall. So that's usually why we say 3 and then consider IVF.
Yeah. How does someone start to have that conversation with their provider that maybe they're ready to start exploring IVF as an option?
Yeah, I think it depends on what setting that they're receiving support for IUI treatment. I would say probably if you're coming to a center that already provides IVF, they're probably going to frame it in here's the success rates or ovulation induction, here's success rates or ovulation induction and IUI, and then IVF. So they're already kind of getting you to start thinking about that.
Yeah.
There's lots of providers that are only doing OI and IUI, so likely they're gonna try to, see success with more overall. Someone says, I want to do 10 IUIs. We'll say, okay, you're kind of in the driver's seat with this. We're kind of your expert kind of counselors, kind of recommending pros and cons. But I think it's really important to remember it's their journey. And, some people are open to in vitro and some people are not. So we have to kind of meet people where they are with it. Sure.
Oh, that is definitely good to hear that.
Yeah.
That reminder that you're working with a team and that it is a team, right? That you two are
It is a
working
team.
together and you're not being directed or told what to do, but
Yeah.
you're learning how to collaborate with each other.
Yeah. Yeah. I think providing a plan and framework, but it's very important to us that our patients feel like they have autonomy with those decisions for sure. Everyone's boundaries are different, right? So
yeah,
yeah.
definitely. Okay. So another question that came in, any advice to improve fertility with Hashimoto's when trying to conceive?
Great question. So Hashimoto's thyroiditis is an autoimmune disorder of the thyroid. Incredibly common. It tends to go kind of hand in hand with hypothyroidism as well. And so since it's an autoimmune defined kind of a pathology, other than kind of being on thyroid supplementation, we usually recommend a low dose corticosteroid, which we use fairly empirically in our practice too, meaning that we don't necessarily have a diagnosis. We still kind of utilize it for overall inflammation. And so that could be an additional treatment that this person could try overall. It's low dose because steroids certainly have side effects. So we kind of counsel folks about what that could be and then again have a conversation about whether it's something that they would like to try.
Very good. Are there other thyroid conditions that can affect fertility and how do they?
So classic kind of hypothyroidism, absolutely. And then there is a subset of that called subclinical hypothyroidism. So it's not as severe. For reproductive endocrinology, we have much tighter windows of what we want a thyroid stimulating hormone to be compared to medical endocrinology. So patients are always kind of surprised because on their report, their TSH will look completely normal. And then I'll say, oh, actually, I want you to be on supplementation. So we have a good number of people who are on supplementation. And I think those small things also help with their overall success as well. And sometimes that's all they need to conceive. So great. That's easy for us to find and fix. That's great. We don't mind that at all.
Next question. Thank you for opening up the floor for us to ask questions.
Yeah.
As a person who suffers from PCOS, what have you seen that has been most effective at reducing symptoms like facial hair, acne, irregular periods, etc.? This could be recommendations for things like herbal teas, diet, supplements, therapy, or anything else you can think of. So maybe we can, once again, split this up. We can talk about some of the medical interventions that you might have someone explore, as well as the lifestyle interventions and complementary medicine that you might have them explore if they have PCOS.
Sure. Yeah. I would love to kind of start with the latter, which I think is more your expertise of kind of more lifestyle, because I think that's actually first line. First is always kind of seeing if there's improvement in diet, movement overall that can help. And we will always talk through that first. It's just hard to do. And I would love to get your feedback. I'm happy to kind of talk through what I tell patients, and you can kind of tell me if it's overall something you recommend, if there's kind of, special cases. So, we frame it all as a disease, PCOS, a disease of insulin, right? And so anything we can do to kind of decrease the insulin spikes is helpful. So we really like those continuous glucose monitors because it helps teach you about what you're eating overall. I'm seeing a little bit of a smile. So are you
Taking
okay
it
with
all
that?
in, taking
Yeah,
it all in.
yeah. Um, and, certainly kind of higher protein, less kind of carbs is helpful. I'd love to hear kind of your thoughts about intermittent fasting if you're open to that. I will share kind of my personal journey is that I'm on the done with my family building and kind of in that more late 40s time where all of a sudden I'm researching a lot about perimenopausal diets. So that's kind of where I'm also learning this is kind of what's best for overall kind of insulin control. So actually questions for you if you don't mind.
I was not prepared.
Oh,
I
sorry.
will
Yeah.
say that I tend to take a health at every size. We might call it, some people might call it intuitive eating approach
Uh-huh.
to nutrition. And that's
Mhm.
because so many of the people that I've worked with have had a history of disordered eating and
Mhm.
have had a long history of restrictive eating. And so I tend to focus more so on what can we add to your diet. I find that that naturally crowds things out that maybe aren't so supportive. And it also just creates a balance within the diet where we can and we need carbohydrates, right? We can still enjoy lots of cultural foods. I know so many of the people I've worked with, like white rice is a staple. And I have no intentions of encouraging them to give that up. So rather than thinking we have to get rid of the carb rich
You're
foods,
adding.
it's how can we add fiber? How
I
can we
like
add
that.
protein and fat?
Yeah.
But I think I always stand first in the place of I want to make sure that I'm not adding to this pressure to
Mhm.
diet or this pressure to undereat or in any way restrict because people with PCOS are already at an increased risk of developing eating disorders. And it just seems so common in this population for people to feel like the first thing they need to do is restrict. So
Yeah,
that's where
that
I'm
makes
at.
sense.
Yeah.
Yes. We talk a lot for anyone who's kind of interested in lifestyle modifications that it's not a number on the scale and don't really look at BMI. It's much more kind of toning muscles and just kind of feeling healthier, just so they can kind of define what that looks like for them. So that's kind of the lifestyle portion is it's all the easy things, but hard things. Get more sunshine, that'll increase your vitamin D, get some movement, and kind of what we talked through about kind of preferences for higher protein foods overall. On the medical side, as you know, there's like a dizzying array of now medications that can be utilized. And I'm certainly not an expert in them, but get asked about it quite a bit. And I will say that there's different spectrums for PCOS. And so anything that could possibly help if it motivates a patient or client to utilize them, I'm happy to help overall. And that includes, the ever popular now GLP-1s that, if they are utilized to kind of ameliorate PCOS kind of symptoms, they can be quite effective. And I know we don't have enough data yet about, full safety and efficacy. But that said, we do have enough to say, okay, if you want to do this as kind of a pre-treatment to your treatment, makes total sense. Let's go for it. And we kind of balance that with how long they've been trying to conceive, how ready are they to kind of get going, what their age is, and kind of make decisions based on that. But there's no question that, an increased body fat percentage ultimately kind of trickles down to the egg. It all starts with the egg, right? And so like a high cholesterol, high fat diet, if it's really skewed one way, could really be affecting even the machinery in the egg itself. The oocyte, the human oocyte or ovum is the biggest cell in the human body. It's still naked to the eye, it's a naked eye, but you can't see it. But overall, it's still actually quite massive. And so that machinery has to work well. And we already know that that kind of machinery doesn't work as well if it's a high fat, kind of high glucose environment for those cells.
Yeah, that's definitely helpful. Okay. Actually, someone had a specific question about birth control. They were wondering the role of birth control in managing PCOS. Now,
Mhm.
clearly, it wouldn't make
Right.
sense to put someone on birth control when they're trying to conceive, but can you
Yeah.
talk about how birth control can help people manage their symptoms with PCOS?
Yeah, I'd love to. So I feel like birth control pills get a bad rap, but they're actually quite useful in our world for treatment of PCOS, which I'll talk about in a sec. Treatment of endometriosis are kind of the two kind of main things, or kind of any general abnormal bleeding. So they're quite versatile in terms of how to utilize them for effectiveness. So for PCOS specifically, for BCPs are quite effective in actually increasing sex hormone globulin. And what that is essentially, it's a carrier for your free testosterone. And so the symptoms of increased acne or hirsutism, that's hair growth in places that you're not used to, is all related to testosterone levels, free and total, which are actually kind of hard to actually kind of measure. You can measure them, but it doesn't really give you an accurate kind of reading of how high it is unless it's really high. So what the BCPs do is that they increase the SHBG, which then will decrease your free testosterone. And so they can be very helpful actually for if you're having specifically kind of acne or hair growth kind of challenges overall.
Good to know. Definitely good to know. You're right. There's definitely been quite a bit of pushback, I think, against birth control being used for anything other than preventing pregnancies, but they have a role.
Yeah, I'm happy to be a little bit of a myth buster. It does not cause infertility at all. In fact, the actual probably absolute highest chance of fertility is right when you stop birth control pills. There's lots of folks who say that they stopped their birth control pills and they never had a menses, and that's because their fertility was at its peak, and so they conceived immediately afterwards.
I love it. I'm all about myth busting around here.
Yeah.
We like the truth around here. So thank you for sharing that.
Yeah.
Okay, so we have one more audience question, and then I have a question that came up as I was looking through your website. So we'll ask the audience question and then I'll get to mine. So this person asks, what is the oldest age that you've known a woman to get pregnant? Do you think there are any advantages to being an older mom or mom?
Yeah. Yeah, I really love that question because it's medical, but it's also kind of life in general, right? So the answer to the oldest natural conception is 59. The assisted conception, I believe, was 77. That is most definitely with assisted reproduction and usually third-party reproduction, which means likely donor oocyte or donor sperm or some combination of the two. So kind of 50s is probably the oldest for spontaneous conception, which is that age gap is wild overall. Our oldest patient is about 53, and that was with the help of third-party reproduction overall. And the advantages of being an older mom is I think, you're established with who you are a bit more, certainly maybe professionally. And so there's a lot of stability, I think, that you can provide. I will say there's not a lot of easy choices with conception 40 and above. It seems like every possible kind of thought is hard. And we're seeing about 50% of folks kind of around age 40 are dealing with fertility, overall infertility challenges or fertility challenges. I don't see the other half that are like, oh no, it just worked, and they go to their OBGYN, right? So that's what I tell everyone is that we're just coming at it with the different kind of biases based on the populations that we're seeing.
Absolutely.
Obviously all there to support. Yeah, it's pretty stark kind of who's kind of on which side of that and who we need to help.
Yeah. So this last question, which comes from your website, is what is PRP?
Yeah.
And how can it help?
So PRP stands for platelet-rich plasma. So it is being used in many different specialties and fields in medicine, but it's essentially we draw someone's blood. It's generally about 50 cc's, and we have a very specialized kit, which then isolates the plasma itself with the platelets. And the thought is that it's a natural kind of powerful cocktail of growth factors and cytokines to kind of promote kind of either ovarian rejuvenation, which I know this is kind of a vague term in terms of what's happening. So I'm happy to kind of talk through what that looks like when we're actually performing it. It's generally, we've been utilizing it for the ovaries. So someone with diminished ovarian reserve, maybe normal ovarian reserve, but lower egg quality. It is a very new kind of intervention that does not have a ton of solid data around it. And so I'm always when someone comes to us asking about this, I always say that it generally meets criteria for something that we're willing to kind of help with and see is that it is safe, right? It is not, very, very expensive. It's, within realms of affordability, and it could help, right? And if any of that kind of starts to fall away, if we're seeing that somehow it's detrimental, which we're not, or if it's not really going to be helping, then, evidence-based will kind of move on. But, our whole field is geared towards trying something new. Someone's brave enough to try something new and see how it works. The technology that we use the most is less than 50 years old, so, there's always something new to discover. So we do provide it for that reason. So it's considered a same day procedure, and we perform them with light anesthesia, just because we do have to access the ovaries to place the PRP back.
Very good. So you use the term ovarian rejuvenation.
Yeah.
What exactly do we mean there?
I don't usually use it so much, but I see it used a lot with ovarian PRP.
Yeah.
Generally, we're looking to see if it's kind of helping with their follicle count.
Okay.
If it's helping with, if they're, a lot of times I've already done IVF, or they're going to, commence IVF treatment, to see if it's helping with their embryo quality and the number of embryos that they have. Those are the general kind of factors that we're looking at.
Awesome. Thank you so much for answering that. I've definitely heard the term kind of tossed around, but I haven't seen a lot of people explain what it means. They're just kind of like, you can add this on. So thank you for
yeah, sure.
filling in the blanks there for me.
Yeah, absolutely.
Great. So we are almost done. We're coming to a close. So I wanted to ask you, what's one thing that you hope that anyone who has watched this would walk away knowing or feeling?
I hope that you feel more empowered with kind of education. And thank you. These have all been amazing questions. I want to thank your community for taking the time to ask them, really, because that's how I think we're kind of able to educate more. We view our role in Arbor Fertility as kind of being within the community. That's part of why we have like all these satellite offices for accessibility, and part of that is, kind of just getting this information out there, because it's better, but there's still a lot of stigma around kind of fertility overall and fertility care. And so I want to see all of this more normalized for sure. And 100% believe that, diet is a huge part of what's going on. So this will be an ongoing conversation about how we can do better to kind of create an environment and program that's really supportive instead of restrictive, as you said.
Very good. Very good. So where can people learn more about the work that you do and maybe get in contact with your office?
Sure. Yeah. So our website is arbor-fertility.com, and our phone number is 314-806-BABY. 2229.
I love that. I will make sure to include links to your Instagram, as well as your website and your phone number and your information down in the description box below. Thank you again for answering all of these questions and taking time out of your busy day to chat with me.
Likewise, it's been a really honor and privilege. I can't wait to kind of see if it's been helpful, really. I'm hoping we can connect again. Thank you, Kendra.
Sounds good. Bye.
Bye.